Thank you. Before I invite the next speaker, I would like to announce that we are totally pleased to, as a gesture of solidarity to our medical fraternity, we are offering a professional indemnity worth rupees 10 lakhs to all our delegates who are attending this conference. So yes, congratulations to all of us. May I now take the honor to invite Dr. Deep Goyal, Sir, is Principal Director and Head of the Department in Gastrointestinal Oncology Surgery Department, BLK Max Super Speciality.
Thank you very much. At the outset, let me thank Dr. Mishra for making us part of this such an academic feast. And it's a matter of great pride for me sharing the same academic platform as Dr. Chaube, who has been my mentor, and he's touched my life in more than one way. Today, as we know that number of cancer patients is increasing at a rapid pace, it is almost reaching an epidemic level in our country. And the moment we say rectal cancer, the first thing which comes to our mind is a stoma. And I think that is something which needs to change. And as Dr. Ashok was telling, genetic engineering, and we're talking about artificial intelligence, I think this all plays a great role in organ preservation and taking a leaf out of breast cancer surgery, where when we were in training we used to do radical mastectomies, and now we talk about breast conservative surgeries, almost only just doing lumpectomies. So this is the way we are going in rectal cancer, and I will take you through the journey. I have no conflict for this particular talk. This is the timeline of rectal cancer surgery, starting from Professor Miles in early 1907 to Antonio Lacy, whom I had a privilege to work with, where he's talking about transanal TME. So I think we have traveled a far distance. And the earliest description of rectal cancer is in 14th century, where it was described as a bubo. Bubo is a hard mass which does not pain. So that is from where we are coming. And this is a legendary, almost like a godfather of the rectal cancer, Professor Bill Heald, and who said that, for me surgery is primarily a craft, and I see little shame in regarding a surgeon as a person who exists only to do operations. Well, today I'm standing on this podium and telling you that probably in some time the number of surgeries for rectal cancer are going to reduce drastically. The protocol has changed from only surgery to multimodality. And if you look at the surgery of rectal cancer, there are various complications: anastomotic leak, one of the Achilles heel, bleeding, anterior resection syndrome, urosexual complications. You'll be surprised to know that around 40 to 50% of the patients who undergo rectal cancer surgery will complain of urosexual problems in some form or the another. Anastomotic leak, again, is a very, very dangerous complication. All of us know that. And literature tells us that the incidence ranges between 10 to 25% in various series. There are certain game changers which have, enabled us to do minimal and minimal in rectal cancer surgery. And first thing is MRI of the pelvis. So you will be surprised that even today, when a patient comes to us, he will have a PET scan done, but not the MRI done. However, the MRI is the most important investigation for a local staging of rectal cancer. I think we must understand that. And today, if I can give you that message, that no patient of rectal cancer should be operated or should be chosen for any therapy without an MRI pelvis, I think I will do my job. And this was highlighted by Gina Brown, that you can measure and know so many things in an MRI, and to also understand what mode of treatment is applied. After giving radiation or chemotherapy, you can reassess the response of these therapies and do a repeat MRI, which is called YMRI. And there are tumor regression grades today available, which will enable us to measure the response of the treatment. So today we are talking about total neoadjuvant treatment. Total neoadjuvant treatment means that before opting for a surgical procedure, if you have to opt, you can complete the total treatment in the form of radiation, whether it's a short course radiation or a long course radiation, and we can do all the chemotherapy. Then we can choose whether patient requires a surgery depending upon response of the treatment. If patient has a complete clinical response, you can choose to do an organ preservation, which is called watch and wait policy as well, or you can choose to do a minimal invasive approach where organ will also be preserved. So this is the standard today of management of rectal cancer, that stage 2 is stage 3 cancers. You will give neoadjuvant treatment in the form of radiation and adjuvant treatment, and then if required, patient will undergo surgery, probably minimal invasive surgery, or if there is a complete response, we'll do wait and watch policy. And the incidence of complete response today is in around 15 to 25%. So we have to also look at what does patient really want. Is patient really wanting that you do surgery? No. What is patient wanting is an organ preservation, but at the same time achieve cure. Avoid a permanent stoma, maintain quality of life, and avoid any complication which is there from surgery. This is a very interesting survey, and it showed that avoiding a stoma was as meaningful for a patient as the cure of the surgery. So if you say, I will give you cure, but you will have a stoma, patient is not happy. If you say, I will avoid stoma, patient is happy. And if you say, I will give you cure, patient is even happier. So avoiding a stoma is one of the very important things. So coming to the total neoadjuvant therapy, there are a lot of trials available. Prodige trial, where you give induction chemotherapy, then you give induction chemotherapy in the form of FOLFIRINOX, then you do long course radiation therapy, another chemotherapy, and then response rate as shown here has increased to around 30% from 15%. Rapido trial, here you use short course radiation, but the response rate is again very good, around 30%. Prospect trial, so now we are moving a step further. We are saying, can we avoid radiation? Because radiation itself may have some morbidity. So only chemotherapy has been shown to be as effective as a combination of chemotherapy and radiation, as our knowledge about the newer chemotherapy agent is increasing. So advantage of TNT, as I said, is chemo tolerance is better because the tissue planes are not violated, they are well vascularized tissues. And once you do not operate and give chemotherapy or radiation therapy, you can choose, if there is a complete response to these patients, you can avoid any surgery and you can obviously save the sphincter. Complete clinical responders, this concept was first brought by Angelita Hybergama from Brazil, very famous lady. What it does is that it completely gives you clinical and pathological response, and you can assess that by your digital examination, by doing an MRI, and by doing a sigmoidoscopy. If there is a flat scar or a whitening of mucosa, you know that probably there is a complete clinical response. You can do biopsies. Only limitation is that patient has to be in a very, very strict follow-up. You can't have a patient where you have done a total neoadjuvant treatment, patient has responded completely, you put him in a watch and wait group and patient disappears. Patient appears after 3 years. No, that is not possible. You have to have a very strict follow-up for these patients. So if you look at this literature, local recurrence may develop in around 30% of cases. That means 70% of cases were avoided surgery, and more than 50% of the recurrence were in first year. So you have to be more vigilant during the first year. And among the recurrence, 90% of the patients were salvaged. No surgery was required. Organ was preserved in 78% of the patients. So we are talking about 30% recurrence. Out of these 30%, 78% did not require organ removal. So that's a huge thing. After radiation or after TNT, if you have downgraded the disease, you can still preserve the organ by doing TEMIS, that is transanal excision minimal invasive surgery, where you can do the full thickness excision of just the tumor, not the organ. Organ is preserved. And there is a lot of literature available which says that for early stage disease, T1, T2, you can do TEMIS. And they have compared it with the rectal dissection, and they have found that over a period of 9 years, there were similar oncological results. Another trial, GRECA2, 5-year results, same results. So I think it's very clearly available and visible by our literature that we can preserve organ in a huge percentage of patients. Even if you have to do surgery, initially when we were under training, we were told that we have to do surgery after radiation within 4 weeks or after 4 weeks. Today we are talking about waiting for 8 to 12 weeks, and now latest literature is that we can wait up to 18 weeks. So the pathological response improves further. So longer you wait, the better it is. You all must have read in the newspaper that these are a cohort of 5 patients. They were treated in Memorial Sloan Kettering Hospital. This is a subset of a rectal cancer patients where mismatched repair deficient gene was there, and they gave immunotherapy to these patients. Direct immunotherapy, no radiation, no chemotherapy, and tumor disappeared in these patients. But this is a very small percentage of patients where we have decoded their genetic print. And I'm sure in times to come, more and more rectal cancer genes will be identified, and they will be susceptible to immunotherapy, and they will behave in a similar way as these 5 patients have behaved. So imagine patient coming to a doctor with a rectal cancer. You take a tissue, you send the tissue for genetic sequencing, and we find out which gene is problematic, and we give immunotherapy to tackle that gene, and the disease disappears. And this is, believe me, is the future of probably all cancers, but more true for rectal cancer. Liquid biopsy today, we can take a blood sample and diagnose the recurrence of the disease. You can diagnose the DNA of the tumor cell even before it appears in any imaging. So you can follow up these patients, and by doing this liquid biopsy, you can find out that there is a probably likelihood of recurrence. Personalized rectal treatment, this is the future, as I said, that next generation sequencing, and then you will know which patient requires what kind of treatment, whether he requires target chemotherapy. And gene editing, again, as I was saying, forget about giving immunotherapy. We can delete the gene and do the gene editing, so for the future your children may be free from the cancer. So to conclude my talk, I will say biology is the king, case selection is the queen, and the technical maneuver undertaken are the prince and the princesses. And we as a surgeon sometimes get into the habit of thinking that we are the kings, but it is not true. Only fool learns from his own mistake. The wise man learns from the mistakes of the others. Thank you so much.
I'll request all the speakers to come on the stage. I request the chairpersons to felicitate our speakers. Dr. Rajesh Shah, Dr. Arun Prasad, Dr. Ashok Puranik, and Dr. Deep Goyal to please come on the stage. Thank you so much.